Okay. Okay. So the for a hint for you guys, I generally 9 times out of 10, this question is used in relation to alcoholics, the malnourishment related to alcoholics. But there is a triad you can notice here: confusion, the nystagmus is an ophthalmoplegia, and ataxia, three. So this is Wernicke's encephalitis. Now, if you wouldn't have picked that up, you could have picked up the fact that she's severely malnourished, right? So, what is going to be something that happens in malnourishment? Well, think about thiamine or B1, right? B1, right? And malnourishment. And if you think about that, I generally think about alcoholics with Wernicke's encephalitis and Wernicke-Korsakoff syndrome. But this is the triad for B1 deficiency. It's not truly the alcoholism, it's the degree of malnourishment, which is what this girl um, is going is happening. Actually, if y'all want to know something crazy, so she was already super deficient, right, in thiamine. She had very little thiamine to begin with. And then they said her parents were like, "You don't feel good. Why don't you eat? Why don't you eat some sugar?" Right? And then that'll make you feel better. Well, the little bit of thiamine that she had what left, the little bit that she had in her system was used to metabolize this without correcting it. So it put her in a hole. It actually made it much worse. So she had a little bit of thiamine, but she used it all up. And then it put her in a severe deficiency. So yeah, be careful with that. All right. And that's what we talked about here. All right. All right. I can't feel the heat. burn his hands, so sensory loss. Can't feel the heat, huh? Um, right. So what pathway is this? Pain and temperature? ALS, right? Right. So when we're looking at this, that's the main thing. But let's dive a little bit deeper. We have a decrease reflexes in the upper limb. Okay. Increase in the lower limb. Okay. So that tells me I have a lower motor neuron lesion up top, upper motor neuron lesion below it, right? Because we would expect at the level of the lesion, you would have a lower motor neuron lesion, flaccid paralysis, hyporeflexia. Okay. But at the level, let's say, I think it's the lesion somewhere around here. At the level of the lesion, you're going to have these hyporeflexia, but everywhere below it, remember, is under an upper motor neuron lesion parameters, right? An upper motor neuron. So you see hyperreflexia. Okay, so if you remember, and it may not be easy, but if you start crossing these off, if you get to this one, you remember one of the key things that it has this cape-like distribution of the upper body, of the upper limbs. You lose the ALS, you lose pain and temperature of the upper limbs. That's one of the major components of it. Okay, that's the first component. Now, if the lesion is large enough, it could result in a lower motor neuron lesion at the level and an upper motor neuron lesion below. But in its infancy, when it begins this syringomyelia, the first thing you're going to see is this ape-like distribution, this loss of pain and temperature across the wherever the level is, which is typically on the thorax. So I'll show you guys a picture. Um, but this is very classic for it when you see you need to if you had to break this down, you would say you would want to break it down by which pathways it involved. So this pain and temperature ALS. So I know that it has to be a part something with the ALS. Okay. Sensory though, right? Not just motor. Then we have lower hyporeflexia in the upper limbs, hyperreflexia in the lower limbs, and some decreased muscle tone. Okay. Hand muscles are atrophic. Okay. So look, this is the syrinx, right? The point is the syrinx, let me use the red. Excuse me. The syrinx is widening this area here. And if you remember, the ALS, our pain and temperature, crosses right across this area, literally right there. So the first place that's impinged are the crossing fibers, these crossing fibers that give you your pain and temperature. Okay, so you get that tape-like distribution because you're hitting it right here where they cross. It's bilateral. Make sure you know that. Cape-like distribution, bilateral. Now, if it gets wide enough, then you start messing with other things. But the main thing they have to tell you that you lost the ALS first. Bilaterally, generally upper limbs, right? Because these syrinx that they use form around the neck or in the upper thorax. Okay. So be careful. Central cystic dilation, and then it'll impede, and the ALS, those crossing fibers are the first things that you come across. Bilateral. Disease, please. Anybody?
Paget.
Yeah,
Pat.
very good. Very good. Yes, bone expansion. Bone expansion. Typically, they didn't do it here, but they'll tell you the person's hat size went up, right? Foot size, hat size. They wear a larger hat. That means their skull's actually thickening. So yeah, this is Paget's. Now, the big thing to remember, which is crazy about Paget's, is that you get a normal calcium and a normal phosphorus with Paget's. Okay. Now, the key thing about Paget's, if you remember, alk phos is a sign of bone turnover. We see it in bone cancers and stuff. Bone turnover. What is Paget's doing? Bone turnover. Okay. So you will get a normal calcium, a normal phosphorus, but you will show a high degree of turnover. Okay, so E's going to be the correct answer here. All right, and thickening of the bones. It's not a good thickening type thing. It's very erratic. Stuff's coming in, going in, going out. It's very erratic in presentation. So even though they're thicker, they tend to be brittle. So it doesn't. It's not a good thing. It's not like you're like superhuman or anything. Okay, but this is these are labs. Just keep in mind normal calcium, normal phosphorus just came to mind. Um, Osteoporosis. Women with osteoporosis. What are these values in osteoporosis? Anybody? They're also normal. Even though the person has osteoporosis, you will not, the calcium and phosphorus are normal. Okay. Good thing to remember.
Is ALP normal also
I
in
believe
osteoporosis?
everything's normal. That's why you do it. In regards to the bone, everything's normal. In my understanding, the only that's why you use LH and FSH, yeah, as the standard for menopause. Yeah, but I think I'm pretty sure that the answer is that everything stays normal, which is why it seems weird under the setting. All right, so here's our Paget's disease. Oh, here's a good one. Don't forget this part because this is weird. It doesn't seem like it should go together, but they have hearing problems because the bones get bigger and impede your hearing. So that's a weird one. Remember, the foramen are just those little holes that the nerves go through, and if the bone gets thick, then the nerve gets pinched, right? Well, hearing's one of the first things, or one of the things that can actually, um, because of this, that can go because of this bony growth. Okay, so don't forget the hearing part of it. All right. Does anybody remember the mnemonic to remember this? You lick your lesion. Yeah, there you go. You lick your lesion, lick your wound, lick your lesion. So the tongue is going to deviate to the side of the lesion. So it's going to be on the left side. Now you can double check yourself, right? So if we have a lesion in the medulla, cranial nerve 12, right? Remember the fibers for the legs or for the body, they cross, right? Before they get there. Okay. So if you lick your lesion and it's the left tongue, it's deviating to the left because the the weakness, right? The cortical spinal tract that's traveling down because it's crossed above the lesion. This is the area of decussation. You should expect that the symptoms of the body would be on the opposite side, the contralateral side, because the lesion is in the medulla and you decussate underneath that, before that, if you were coming up, right? Okay, so if you remember all the cranial nerves are ipsilateral. The cerebellum works ipsilateral, but these cortical spinal tracts converge and cross. They decussate right before you get to the brainstem. So if you're going to have a left tongue issue, you're going to have a right body issue. Okay, and we know um, as it stands, the cranial nerve 12 actually runs in the middle. That would be hard. That's really not fair, but um, it just runs in the middle. I don't know how else you would know that unless I just remember the tongue is in the middle and the 12 runs in the middle. But yeah, lick your lesion, okay? So this is one of those ones if you remember it and you see it on the exam, you don't even need to get into the right side of the body, flipping over. You just go deviates to the left, lick your lesion left, and if you remember, it's medial. Um, I think I have a picture of the brainstem coming up, and I'll show you where it is. But as you can see, um, cranial nerve 12 you'll lick your lesion on the left side. But remember, all of the cortical spinal tracts, the motor movement, those cross. Okay. So you're going to get right side motor problems with the left side tongue issue, leftward tongue deviation, left hypoglossal nerve, right hemiparesis because it crossed over. It decussates below the midbrain. Okay. So take your time, go slow with these. I don't know if they'll make it any harder than this, to be completely honest. This is as comfortable as I felt doing these. So, yeah. All right. So what we see here, they're painting a picture, papilledema, early morning emesis, right? They're painting a picture of this kid has increased intracranial pressure. eyelid retraction, the eyes are bulging out. Okay. So what happened? It's been about a month. That's fairly acute. What happened that can cause a 4-year-old to have increased intracranial pressure, considering they don't say anything about a fever or meningitis or whatnot? So what we're looking at here is some sort of obstructive hydrocephalus. Pretty simple, right? Some sort of hydrocephalus. He's 4 years old, so maybe there was some sort of obstruction that would explain everything. So that's kind of what they were getting at, a brain mass that's going to lead to increased intracranial pressure. So that would mean an impingement. So if we kind of trace where all of the cerebral spinal fluid goes, there's your cerebral aqueduct, and it's going to kind of travel down here, right? Okay, so if we're looking at a picture right now, where would be the pinch point? Where would it be? Well, as it happens, the worst point in my understanding, the cerebral aqueduct is kind of a pinch point right there. That part, the third part of the ventricle. And C is actually the pineal gland, and it actually is pressing right there. But the cerebral aqueduct is a common place. And if I remove my mark, you can see how thin this area is. Okay, so that's a common place of that can be obstructed and cause backflow hydrocephalus, right? B, if you said B, I mean, yeah, I guess kind of right, but it's just sees a more, it's more pressing on this little constricted area. Okay. Tough question, but obstructive hydrocephalus, you should be able to see that. And if you're looking at the picture, I mean, and you follow the track, you're between B and C, just know that that pinch point right here is really bad. So that can cause it, right? It's actually a pineal gland that's pressing down externally on this on the cerebral aqueduct in this area right here. Okay. So be careful with that. Whenever they talk about a kid, papilledema, headaches, nausea, vomiting, all of a sudden, yeah, I just. All right. So there's a two-thirds, one-third rule. The anterior spinal artery supplies the anterior two-thirds, or the two-thirds of the spinal cord. The posterior supplies the dorsal columns. This is your DCML, the stuff that's lit up. But if you knock out your anterior spinal, you will knock out the entire anterior two-thirds. That includes your ALS, includes your lateral cortical spinals, those autonomics that come through. Basically, the only things preserved is your DCML. That's preserved. Crude touch, SGU doesn't teach this. Technically, I know it's pain and temperature, but crude touch falls under ALS. I know DCML does fine touch and stuff, but crude touch, you should do crude touch, pain and temperature. Okay, that's ALS technically. Um, okay, so we knocked out ALS. We knocked out ALS here. ALS is gone, so you're down. Pain and temp, that's gone as well. Same pathway, and then we knocked out our no our laterals. So the only thing that's going to be normal is your proprioception because you kept the DCML intact. Right. So A should be the right answer. Don't make it more complicated than it needs to be. If you're like, oh God, I don't know what's all this area, well, then what about this area? That's your DCML. You know that, right? So everything except that, yeah. All right. This is where, okay, so wait, can we do this? What did you say? Three, four. 4, 6, and 12. Is that right? That would be right, huh?
Yeah.
Are supposed to be medial. So
Mhm.
four is medial, but it wraps around it, hugs it. It's the only one on the other side. So these wrapping around are four, but they do originate in the middle. Just they're just on the opposite side. So three's middle, four would be middle from the opposite side. Here's six. Six is middle, and then 12 is considered, middle compared to everything else. So there you go. Good. There you go. Now, piece of cake, right? All right, we got a buzzing, unilateral, pretty long time. Decrease hearing, unilateral. Okay, couple of things. They tell you he does not use cotton swabs, not been exposed to loud noise. Okay, that's fine. Um, Note also they tell you normal appearing external auditory canal and normal or pink tympanic membranes. So there's we're not talking about a conductive hearing loss. That's what they're trying to tell you. It is not conductive. It is a neurologic issue, okay? That's the best that they're going to tell you. So buzzing is more neurologic, this unilateral. You should know how to, I don't have a question on it, but the Weber Rinne, you should definitely make a note that you know how to do that, right side, conductive, and you should be able to do that pretty quickly. Okay. So review that. So yeah, this is a neurologic issue going on. So the question is, if this is 6, C has to be 7, so D ends up being 8, and 8 is vestibulocochlear. So that will lead to your sensorineural neural hearing loss that he's having. Okay, so a little bit of anatomy here. Um, just be careful with those. One thing I wanted to mention, I think I put it on the next slide. All right, so like an acoustic neuroma, yeah, that's literally what um, they're talking about in regard when they have a cranial nerve 8 issue. The one thing I wanted you to know is that cranial nerve 7, the external acoustic meatus, it travels with the vestibulocochlear nerve. So sometimes you can get acoustic neuromas that will give you facial nerve palsies, motor issues, unilateral motor issues. So I want you to know that with this, with 7 and 8 run together. Okay, so be careful. It might not just be auditory, they may give you motor facial issues as well. This is what it'll probably be. If you want to look at this, just in case you ever come across it, typically you'd see one. But if you ever see a bilateral acoustic neuroma, that's really weird. That's like the only thing I know about NF2. Two, two neuromas, NF2. That's the only thing I know about it. Bilateral. Okay, cool. All right. I put the reference ranges for you guys there too. Look here. I know this is a positive, but when you start talking about things like meningitis, we'd like to see that, right? You can rule things out. So I know that's a pertinent positive and it's easy to kind of look over. But in this situation, I want to know their vaccine status. Okay, who wants to do this one? Somebody do it.
Um,
Oop.
I kind of figured it out just from the glucose. So the glucose
Yeah,
is normal, and
good.
viral will have everything kind of normal. And then since it's a
Yeah.
6-year-old enterovirus.
Yeah, exactly. You're exactly right. You know what? I guess, and it makes sense. The way I remember it is like the bacteria has to eat the glucose. Even the fungus has to eat the glucose, right? So they have to have some degree of decreased glucose. If it's going to be normal glucose, then it has to be viral. Okay. And also the other dead giveaway. Remember, look at this, lymphocytes. Well, I don't want to say dead giveaway, but that pushes you more towards viral versus if this number was high, if we had a left shift towards neutrophils, that would be more like bacterial, right? So that's your two giveaways. Even fever's a little high. You start to get to the 102 to 104. I start really thinking bacterial, but who cares? They gave us the numbers. There is a normal glucose. There's a lot of lymphocytes. The most common by far is enterovirus, Coxsackie to be specific. So that's how you do it. Make sure you know what falls into what. Tuberculosis is a little bit weird. So no tuberculosis in this situation, no the fungal situation, no Guillain-Barré is another one that they use. They use the CSF um, test to diagnose Guillain-Barré. I believe it has something's massively elevated, like the proteins are like through the roof or something like that. But anyway, so make sure you know, like I said, viral, bacterial, mycobacterium, tuberculosis, your fungal stuff, Guillain-Barré. I think that's like the five that they really talk about in New World. But oops, okay, there we go. Sorry. Okay. Right. And then here we go. This is straight out of first aid, right? So I go glucose first all day, right? So decrease glucose because they have to eat it. They eat the glucose. Viruses don't. Protein, you would expect a high amount of protein because there's stuff there, right? And then look at fungus. Look, fungus and TB. TB is a bacteria technically, but look, fungus and TB prefer lymphocytes. That's a big deal, right? Because you're going to see lymphocytes, and you're like, oh, that's viral, right? And it's like, hold on. That by seeing high lymphocytes, you're just eliminating that it was bacterial. It still could be viral, fungal, or TB technically, right? Okay. So these are easy points. Don't get these wrong. You know, solitary, ring enhancing lesion. All right. Okay. So we're thinking meningitis to encephalitis. If she's got a full-blown lesion um, here, septic, so some sort of bacterial infection got up here. I think like staph, probably something like that, staph or strep, probably staph. Um, but yeah, ring enhancing lesions. Now keep in mind, solitary lesions typically mean that's the primary process. That solitary lesion is the primary issue. If you were to get a bunch of them, maybe it is metastasis. Make sure that makes sense in your head. If you get a bunch of liver spots of tumors, it's likely that it metastasized there. That's why there were so many. Versus if there's a solitary lesion, that's usually the primary lesion. Okay, so because there's a solitary lesion, it's our primary lesion, okay, and it's at the left lateral temporal lobe. So we just have to ask ourselves, what's the easiest route to get there? Well, we know she was pulling at her ears, and if y'all remember, mastoiditis is when you get that swelling behind your ears. Well, those mastoid hair cells are a very easy conduit to the meninges and into the brain. So if you're going to get temporal lobe encephalitis, and she was pulling on her ears, the mastoid hair cells are the closest thing. Frontal and ethmoid, you'll probably get frontal lobe issues, but this is specifically temporal lobe, so they want you to little mastoid hair cells. Let's take a look at a picture. This is one of the pictures I want you to be able to recognize. Okay, I want you to be able to see this and think that could be an infection. Okay, now there's a caveat. Um, what's the one? Not it starts with the T. Toxoplasmosis. Toxoplasmosis also gives you, but I believe you get multiple ring enhancing lesions with toxoplasmosis. Also, CNS lymphoma, I believe, can give you a ring enhancing lesion. Okay. But what you're looking at here in this ring enhancing lesion, this one specifically, this bacterial ring enhancing lesion, is the fact that there's liquefactive necrosis in the middle. Okay. It's all dark. The bacteria broke that area down and you were able to wall it off. Okay. So when I look at these, I look for the ring, or that means it's walled off. And if it's very dark and solitary, especially if the person has been sick recently, I lean towards that. Okay, but when you do questions and you get come across ring enhancing lesions, I want you to slow down and review those because Toxo does it, CNS lymphoma does it, and then you can get it with abscess like this, brain abscess. And be careful, CMV is another one you need to be able. You get periventricular lesions. Okay, so a lot of this terminology, be careful with it, all kind of stems around these ring enhancing lesions. It's kind of like a granuloma in the lung. It's like, we don't know what to do with all this stuff on the inside. Let's just put a big capsule around it. Then you end up with a big granuloma to deal with, right? Same thing. I don't know if it's calcium, but it is a shell that you put around it to kind of wall it off. Okay. So, good. Neurocysticercosis. That's a great question. Sometimes in early neurocysticercosis, you won't see anything. The brain scan will be negative. That'd be a messed up question. But what they say in neurocysticercosis is a starry sky appearance. So you get this lit up whole thing. But they're little dots, like the size of the red dots I'm putting in. They're not massive. You can't see a ring around them. They're like a starry sky appearance. Okay. So be careful. Learn this ring enhancing thing now and put it to bed. You'll know it when you see it. It's pretty simple. Okay. Okay. Let's see. So I'll give you a second. Okay. Kid got hit in the eye. Now he cannot look up. This is the orbit. Somebody tell me where the fracture is. Under your eye. Yes, exactly. C. So point C. Now, make sure you make sense of this because there are classically what we classically say is eye issues are cranial nerve issues. Like if you knock out cranial nerve 3, your eye will be down and out. Okay. If you knock out cranial nerve 6, the lateral rectus, your eye will be moved medially, right? This is different. This is an actual functional uh, entrapment. Because you fractured the orbit here, the muscle, the inferior rectus muscle gets trapped in here. Um, gets trapped right there. So the muscle's being held there, so the kid literally can't look up because it's holding his eye down. Okay, so this is different from your classic cranial nerve 3, the eyes down and out or whatever. This is an actual injury to the orbital socket. Okay. And what you see, whenever they talk about this, they always show they always show this. I've never seen a question where the socket's been fractured at any other place. They use inferior rectus and the kid can't look up. That's always the question. But yes, Mary, like V2, right? So if you are thinking about a V2 uh, branch, then I believe E would be the right answer. Yeah. Okay. And I'll show you the picture here. If you look, you can see the fracture, right? It's right here. That's that inferior rectus is trapped there, so the kid can't look up. Okay, and as you can see, that's where the fracture is, and this absent corneal. So the corneal reflex has two parts. The sensory part is 5, and the motor part is 7, facial. Um, okay, so if you fracture right here, then you are going to affect, excuse me, the cheek area. Okay, the infraorbital nerve is a branch that comes off. Excuse me. Oof, okay. All right, so be careful with these fractures. They can give you this picture and expect you to recognize that there's a fracture. The kid can't look up.